Hello everyone. Welcome back to the series of lectures in endocrinology. All this while we have discussed about the disorders of anterior pituitary. So now we'll be moving on to the disorders of your neurohypophysis or your posterior pituitary. So let's begin. So the posterior pituitary is involved in the production of two hormones. Which are the two hormones? It is your vasopressin or your antidiuretic hormone and your oxytocin. So let us understand the basic functioning and the physiology of your neurohypophysis. So the first hormone that we should be learning is your vasopressin. Vasopressin is also called as your arginine vasopressin or AVP, and it is also called as your antidiuretic hormone. Now as the name suggests, what is the meaning of antidiuretic hormone? That means that it is inhibiting your diuresis. That means that it prevents your excessive diuresis. Okay. So this ADH is basically a nonapeptide. It is basically a nonapeptide, which means that it has 9 amino acid residues and it is produced from the neurophysin and copeptin proteins. So its precursors are neurophysin and copeptin. So this is your hypothalamus and this is the stalk and this is your pituitary. So we have your anterior and posterior pituitary. So what happens is that from the hypothalamus, this neurophysin and copeptin are produced. From the hypothalamus, neurophysin and copeptin are produced and they are stored in the posterior pituitary as secretory vesicles. They are stored in the posterior pituitary as secretory vesicles and these secretory vesicles are released. Right? So they are released as and when they are required as arginine vasopressin. They are released as and when they are required as arginine vasopressin. As and when required means what? Whenever there is a change in the osmolarity, whenever there is a change in the plasma sodium, then this can be released. Okay? So basically arginine vasopressin is also called as antidiuretic hormone and it is produced from the posterior pituitary and it is a nonapeptide. It is produced from the secretory vesicles having neurophysin and copeptin. So, what is the function of your arginine vasopressin? So, there are osmoreceptors which are present in the anterior hypothalamus. There are osmoreceptors. Osmoreceptors are basically those which detect your changes in the serum osmolarity. So, whenever the osmoreceptors are stimulated, what happens? Whenever there is an increase in the osmolarity, whenever there is an increase in the osmolarity, plasma osmolarity, normal is we know that it is around 280 to 295. So, if it increases means what? The patient is dehydrated. The patient is dehydrated. So, do you want to conserve water or do you want to diurese? You want to conserve water, right? You want to conserve water. So, this will cause stimulation of your anterior hypothalamus. The osmostat is stimulated and they will be increased production of ADH, there will be increased production of ADH or AVP. There is increased production of antidiuretic hormone so that it helps in restoring your volume. So in a dehydrated patient, there will be increased production of AVP. So whenever there is a decrease in the serum osmolarity, if there is a decrease in the serum osmolarity, there will be a decrease in your antidiuretic hormone. So there will be diuresis. That means they are well hydrated. Okay. So this is your basic functioning. How does your vasopressin act? Okay. So how does your arginine vasopressin act? Okay. Fine. Also, as the name suggests, vasopressin. Vasopressin means what? Vaso stands for vascular. Pressin means it has constriction. So vasopressin also has peripheral vasoconstriction activity and it acts via a different set of receptors for this that we will be looking at. Okay. The next hormone which is produced from the posterior pituitary is your oxytocin. What is the function of oxytocin? This plays a very important role in your labor. It helps in the labor pains, it helps in the contraction of the uterus and expulsion of the fetus. And it is also responsible for milk letdown. It is responsible for milk letdown in response to suckling by the infant. So it is also responsible for milk let down in response to suckling by the infant. So this is about your vasopressin and oxytocin. So now we will look at the various receptors which are involved in your vasopressin action. So arginine vasopressin or AVP basically acts via these receptors. So we have a V1A receptor. V1A receptor is present in your vascular smooth muscle. It is present in your vascular smooth muscle and it is responsible for vasoconstriction. So this is present in your vascular smooth muscle and it is responsible for vasoconstriction. Then we have your V1B or your V3 receptor. The V1B or your V3 receptor is present in the anterior pituitary, and you will be surprised to know that vasopressin is actually involved in stimulating ACTH production as well, adrenocorticotropic hormone production as well. The important receptor that we are concerned with is your V2 receptor. The important receptor that we are concerned with is your V2 receptor. Okay, so where are we looking at? So what is this diagram? Let us just understand. So this is your kidney. Okay, so glomerulus, proximal convoluted tubule, then you have the loop of Henle, and you have your distal convoluted tubule and collecting duct. Okay, so in your distal convoluted tubule, you have some cells which are called as your principal cells. Okay, so this is where we are looking at. This is where we are looking at in your principal cells. So the V2 receptors are basically present here on your basolateral surface. So when your arginine vasopressin molecules come and act on your V2 receptors, what does it do? So what does it do is that it stimulates or it helps in aquaporin 2 channels to go and place themselves in their position. So basically stimulation of your V2 receptor is like a command, and this basically helps in mobilization of the aquaporin 2 receptors to your luminal surface, right? So once these aquaporin 2 receptors are stimulated, this aquaporin 2 helps in transport of water or reabsorption of water in the distal convoluted tubule, and this is transported back to the basolateral surface via your aquaporin 3 and 4. So on the whole, what is your AVP doing? It helps in your reabsorption of water and it prevents diuresis. Okay, so it acts via the V2 receptor and the aquaporin channels. Fine. So this is about your various actions of vasopressin or antidiuretic hormone. So what is the T half? T half is around 10 to 30 minutes, and where all is your vasopressin degraded? It is degraded in the liver and in the kidney. Okay. Apart from this, another very important point which you have to know is that it's not only your vasopressin which is involved in osmoregulation, you also have your thirst. Thirst is a very, very important physiological process that helps in maintaining your osmoregulation. Okay, so the thirst osmostat is 3% higher than the AVP osmostat. The thirst osmostat is about 3% higher than your AVP osmostat. Why is that so? Why is that so? Because if the body is not able to maintain its osmoregulation, if the body is not able to bring back the body to the normal osmolarity with the help of AVP, it's beyond the capacity of AVP, then your thirst center is stimulated, right? So that means what? Your body has to maintain your balance, right? It has to, now a patient is dehydrated, your AVP is up. AVP will ensure that he does not keep on diuresing and the volume status is maintained. But beyond a point, there will be a point where AVP cannot maintain the osmolality or bring it back to normal. So beyond that, what is stimulated? It is your thirst center. So thirst center is stimulated so that somehow he tries and drinks water. Okay. So thirst osmostat is set at a higher level such that whenever the osmolarity cannot be controlled by the AVP alone, that is when your thirst center is stimulated. Okay. So this is about your basic physiology. Now let us move on to the disorders of your neurohypophysis, and the most important is your diabetes insipidus. Okay, so this is not diabetes mellitus, this is diabetes insipidus. So diabetes insipidus is basically a disorder where there is a deficiency. There is a deficiency of your arginine vasopressin or antidiuretic hormone. So if there is a deficiency of antidiuretic hormone, what will happen as a result of which? There is excessive diuresis. There is excessive diuresis. Okay. So how do you define your diabetes insipidus? the 24-hour urine volume is more than 40 ml per kg, that means it's more than, let us say in a 60 kg male, it is more than 2.5 liters. And the urine osmolarity is also very low, less than 280. That means that he passes large quantities of dilute urine. He passes large quantities of dilute urine. So they pass large quantities of dilute urine. So what are the other symptoms with which patients of diabetes insipidus will present with? So they can have polyuria, increased urinary frequency, nocturia, and because they have increased amounts of passage of large quantities of dilute urine, it can result in dehydration and hypernatremia. It can result in dehydration and hypernatremia. Okay? Fine. So this is about diabetes insipidus. Now let us look at the different etiologies for your diabetes insipidus. So first is your pituitary or central cause. So whenever there is damage to the neurohypophysis, there can be damage to the neurohypophysis due to multiple reasons that we will be looking at. So damage to the pituitary is what results in your deficiency of AVP, which can result in your pituitary cause for diabetes insipidus or central diabetes insipidus. Then we have your nephrogenic DI. Okay, so what is nephrogenic DI? The basic pathophysiology behind your nephrogenic DI is that there is resistance. There is resistance to the action of AVP. There is resistance to the action of AVP. We know that the arginine vasopressin basically acts via the V2 receptor. We know that the arginine vasopressin acts via the V2 receptor. So if there is a resistance to the action of this on your distal convoluted tubule principal cell, then you can have nephrogenic DI. Okay. Then the third cause is your gestational DI. So what happens in your gestational DI is that there is increased metabolism of AVP in the placenta. So basically the placenta is involved in the degradation of arginine vasopressin. There can be excessive degradation of AVP in the placenta resulting in gestational diabetes insipidus. Okay. Then another condition is called as your primary polydipsia. Polydipsia means excessive consumption of water. Okay, polydipsia means excessive consumption of water. So whenever this is slightly different from your other pathophysiological mechanisms of DI. So whenever you consume excess amount of water, there is suppression of AVP because of excess water intake. So here the excess water intake in itself is suppressing your AVP. Okay. So this can be classified into two types as your dipsogenic and psychogenic. Okay. Dipsogenic polydipsia means that there is excessive amount of thirst. There is excessive amount of thirst. What are the causes that we will be looking at? Psychogenic DI means there is no excessive thirst, but the patient continues to drink lots of water, there is suppression of AVP and they have diabetes insipidus. Okay. So what are we discussing? We are discussing about the etiology of DI and we have looked at the four major causes for it. So we have the primary or the central DI which occurs due to damage to the pituitary. Then you have your nephrogenic DI where there is a resistance to the action of AVP in your nephrons. Then gestational DI, there is increased breakdown of AVP by the placenta. Primary polydipsia is when you have excessive water intake. Excessive water intake associated with excessive thirst is your dipsogenic DI. When there is no thirst and you are just drinking water, it is your psychogenic polydipsia. Okay. So let us look at each of these etiologies in detail. So let us look at pituitary causes. Pituitary causes can be acquired. Okay, it can be because of head trauma, it can be because of pituitary surgery. Then neoplasms like craniopharyngiomas, dysgerminoma, meningioma, metastasis. Then granulomatous diseases. Granulomatous diseases have the capacity to infiltrate into the pituitary. Granulomatous diseases have the capacity to infiltrate into the pituitary. So when they infiltrate into the pituitary, they can cause damage to your neurohypophysis. So what are those disorders? Sarcoidosis, histiocytosis. Okay. Then chronic infections, chronic meningitis, encephalitis, toxo. All of these can also cause damage to your pituitary. Then inflammatory conditions like lymphocytic hypophysitis, then granulomatosis with polyangiitis, which is your vaginous granulomatosis, SLE, scleroderma. All of these can cause damage to your posterior pituitary. Then toxins, vascular causes like Sheehan's aneurysm, then hypoxic encephalopathy, congenital malformations that we have already learned like your septo-optic dysplasias, and genetic conditions. Okay. So when we talk about genetic conditions, we have autosomal dominant conditions when there is a problem with your neurophysin gene. We told you that neurophysin is your precursor to your arginine vasopressin. So if there is an autosomal dominant genetic mutation to your neurophysin gene, you can have diabetes insipidus. Autosomal recessive, again it can be of type A, type B, again involving your neurophysin gene. Then you have another syndrome, autosomal recessive type C, is called as your Wolfram syndrome. Wolfram syndrome. This is also called as your DID mode syndrome. Diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. Okay, so this is your DID mode syndrome, which is because of a problem with your WFS1 gene. So DID mode syndrome is because of your problem with your WFS1 gene. And this is also an X-linked inheritance. Okay. So genetic causes, we have learned problems with your gene for neurophysin can be autosomal dominant or autosomal recessive. Autosomal recessive type C is called as your Wolfram's syndrome, which is DID mode, which is having your symptoms of DID mode. Okay. So this is about the various causes for your central or pituitary diabetes insipidus. So just to revise, pituitary diabetes insipidus can be acquired or genetic. Genetic causes we have just discussed. It can be problems with your neurophysin gene, DID mode syndrome. Acquired causes can be due to granulomas, it can be due to tumors, it can be due to infections, it can be due to inflammatory conditions, it can be due to vascular conditions, it can be due to neoplasms. Okay. Then gestational diabetes insipidus, pregnancy we have seen. Nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus is because of resistance to the action of arginine vasopressin, right? So what are the causes? Very importantly, you have to remember drugs. So drugs such as lithium, dimeclocycline, amphotericin B aminoglycosides, rifampicin, foscarnet and cisplatin. Very, very important. Make a list and try to remember the drugs causing nephrogenic DI. Out of which, very important, lithium. Then you will have to remember dimeclocycline, amphotericin B aminoglycosides because they are very commonly used. Okay. Metabolic causes which can cause diabetes insipidus includes hypercalcemia, hypokalemia. Remember, increased calcium, decreased potassium. Hypercalcemia, hypokalemia. Okay. Then vascular causes like sickle cell anemia, again granulomatous diseases, neoplasms like sarcoma, infiltrative disorders like amyloidosis. Okay. So neoplasms like sarcoma and infiltrative disorders like amyloidosis. Then we can have genetic conditions where there is a problem with your AVP receptor, your V2 receptor. Okay. So this can be X-linked where there is an AVP receptor mutation or autosomal dominant or recessive aquaporin 2 receptor mutation. So V2 or aquaporin 2 receptor mutations can result in genetic causes for nephrogenic DI. So under your nephrogenic DI, always remember drugs. Drugs include lithium aminoglycoside, amphotericin B, dimeclocycline. Okay. Then rarer causes include granulomatous diseases, infiltrative disorders, sickle cell anemia. Genetic causes will be genetic mutations where aquaporin 2 and V2 receptor. Then we have your primary polydipsia. Primary polydipsia can be psychogenic where you have a underlying psychiatric problem as a result of which they continue to drink water irrespective of whether they are thirsty or not, like schizophrenia, OCD. Okay. Then it can be also due to your dipsogenic DI. Dipsogenic DI happens when your hypothalamus is unable to detect the thirst. So there is an impairment in your thirst mechanism. So problems with the hypothalamus, problems with your brain where there is an impairment in your thirst mechanism, for example, head trauma, demyelination, drugs and so on. So this is about the huge list of causes for diabetes insipidus. But if you just understand the mechanism for DI, then the causes you can list out easily. Alright, now let us understand how do you diagnose your diabetes insipidus. So diagnosis is brought about by what we call as the water deprivation test. It is not frequently performed in the current era, but previously what we used was your water deprivation test, and it is always good to know what it is. So water deprivation test basically suggests, as the name suggests, water deprivation means the patient is devoid of water for a period of about 8 hours. So at 8 a.m. the patient is asked to empty the bladder, and what do you check? You check for volume, how much of urine has he passed, you check for the serum and urine osmolality and the patient's weight. So this is at the baseline. You check for the patient's weight, serum and urine osmolality, and how much of volume of urine he has passed. Okay? In the next 8 hours, you check the urine osmolarity, weight every 1 hour, and serum osmolarity every 2 hours. Urine osmolarity and patient's weight every 1 hour, and serum osmolarity every 2 hours. So basically in this phase, water is not given. Okay, so water is not given. You do not give the patient water, and you see whether really he is having diabetes insipidus or no. And you monitor for the weight, you monitor for the serum and urine osmolarity. Now, if the weight loss is more than 3% or the serum osmolarity increases to more than 300, if it is increasing to more than 300, patient is becoming very, very dehydrated, right? So then you cannot continue the test. If you are continuing the test, there is not much weight loss, the serum osmolarity is fairly maintained, then you take a 4 p.m. urine osmolarity. Okay. Now, if the 4 p.m. urine osmolarity is less than 600, if the 4 p.m. urine osmolarity continues to be less than 600, that means what? So, whenever the patient is dehydrated, basically you are trying to test the function of vasopressin by inducing dehydration. So, we had learnt that if the patient is dehydrated, then what has to happen? If the AVP, there is no deficiency of AVP, then arginine vasopressin will increase, right? It has to start retaining. Then what will happen? It has to start retaining your water. Then you will pass concentrated urine, right? You will pass concentrated urine, and your urine osmolarity will have to be more than 600. This is what we are expecting. So when you deprive a patient of water, you will pass concentrated urine. That's what we are expecting. But here the urine osmolarity continues to be less than 600. That means he is still passing dilute urine irrespective of whether the patient is dehydrated or not. That means what? There is some deficiency in your antidiuretic hormone. Okay? So then what you do is you give your desmopressin challenge. You give your desmopressin. Desmopressin is nothing but a synthetic form of vasopressin. You give your desmopressin challenge. Ask them to drink water freely and check the urine osmolarity after 4 hours. You give your desmopressin, check the urine osmolarity after 4 hours. If there is an increase in the osmolarity, what will you expect? If you give desmopressin, then the urine should get concentrated, right? So in a patient of diabetes insipidus, there is deficiency of desmopressin, you do a challenge, you give desmopressin. If there is a good response and there is a increase in the osmolarity to more than 50%, that means what? That means he did have a deficiency, right? So that means that he did have a diabetes insipidus. But if the increase in osmolarity is less, that means he is having a deficiency. But even after giving desmopressin, there is no response. That means there is some resistance, and this means that there could be a probable nephrogenic DI. There is some resistance and there is a probable nephrogenic DI. Okay. So this is your water deprivation test. So in your water deprivation test, what do you do? Let us just recap that. So you at 8 a.m. you take the patient, empty the bladder, check how much urine he has passed, check the serum, urine osmolarity, sodium and patient's weight at the baseline. In this water deprivation test, we deprive the patient of water for a period of 8 hours and see whether your AVP is acting or not. So in 8 hours, in a normal patient, what you would have expected? You would have expected that the urine osmolarity increases and the urine gets concentrated, because then the ADH has to rise. Patient is getting dehydrated, right? He is water deprived. But if the urine osmolarity continues to be less than 600, that means what? It means that the urine is not getting concentrated. That means what? There is no antidiuretic hormone. So then you give a desmopressin challenge. If there is response to desmopressin, then this is a DI, probably central DI. Okay. If there is no response to desmopressin, that means there is resistance to the action of desmopressin, and it means that this could be a nephrogenic DI. Okay. So this is about your water deprivation test. Now let us understand this graph in your water deprivation test. So in this graph, what are we looking at? We are looking at urine osmolality versus time. Okay. We are looking at urine osmolality versus time, and this point is where we give desmopressin. This is where we give desmopressin. Okay. So this is where we give desmopressin. So in your water deprived, in a water deprived individual, in a normal patient, as the time increases, okay, you are not drinking water, as the time increases, you are getting more and more dehydrated. So the urine osmolarity also increases. This is what is given in this curve, right? So the urine osmolarity also increases. This is what is the meaning, right? So if you are not drinking water, you are getting dehydrated, you will start passing a concentrated urine osmolality will begin to increase. Okay. So that is because your normal AVP acts, and the AVP ensures that the urine becomes concentrated. Now, in this condition, what are you seeing? Here, can you see that even after 8 hours, in this graph, there has been no improvement in your urine osmolarity. That means what? You are still passing diluted urine. That means what? There is no AVP. But the moment you give a desmopressin challenge, then your urine osmolarity concentration increases. That means that you begin to pass concentrated urine after giving AVP. That means there is response to AVP. Initially, there was a deficiency of AVP, and after giving your challenge, there is an improvement in your urine osmolarity. Okay. So this is your central DI. Easy for interpretation of the graph. Okay. Now let us see here. Here also there has been no improvement in your urine osmolarity at all. Okay. Despite being water deprived for 8 hours, you are still passing diluted urine. Now you have given your desmopressin challenge here. Despite that, there is no improvement. There is no improvement in your urine osmolarity. So what does that mean? That means there is resistance to the action of AVP. AVP is not able to act. So this is your nephrogenic DI. Now what is this curve? Now let us understand what is this curve. Okay. So in this curve, what happens is that there is some response, but it is not the same as a normal curve. It is lesser than your normal curve. There is no major change to your desmopressin as well. So where is this seen? This is seen in primary polydipsia. Okay. So here there is a suppression of the AVP action. So you cannot concentrate the urine to your normal levels. Okay. That is why this gap here. Okay. So that is seen in primary polydipsia. Alright. So this is about your water deprivation test and the graph of water deprivation test. Now let us understand the approach. Now water deprivation test is not something simple that can be performed, and it's not very convenient for the patient as well. So we have a newer way to approach diabetes insipidus, and let us look at how that is. So in a patient with increased urinary frequency, nocturia, enuresis, you look at your 24-hour urine volume, osmolarity on unrestricted fluid intake. Okay. So if the volume is more than 40 ml per kg and osmolarity is less than 300, what is this? This is nothing but your definition of DI itself, right? So it is definition of DI itself. Then you look at the AVP levels directly. If the AVP levels are elevated, what is DI? DI is deficiency of AVP. Here you have symptoms of DI, but the AVP levels are elevated. That means what? AVP action is not happening. There is resistance to the action of AVP. Resistance to action of AVP means which type of diabetes insipidus? It is your nephrogenic DI. nephrogenic DI. If the AVP levels are low, that means we are dealing with probably a central diabetes insipidus. So you do a brain MRI. And you look for the pituitary bright spot. What is this pituitary bright spot? So normally in your pituitary, in the MRI, the posterior pituitary appears like a bright spot. Okay. So if the posterior pituitary is normal, then you will have a normal pituitary bright spot. If it is present, so pituitary bright spot is also present, then what? It is not a central DI, then it is a primary polydipsia. So in a central DI, there is damage to the posterior pituitary. If there is damage to the posterior pituitary, then your pituitary bright spot will be absent. So in a pituitary DI, your pituitary bright spot will be absent. Okay. So if there is volume is less than 40 but you're still passing dilute urine, you have to do a genitourinary evaluation. Okay. So this is about your approach to diabetes insipidus. So what do you do here? It's very simple. You look at the volume, you have diagnosed DI, you look at whether this is nephrogenic or not by checking your basal AVP levels. If it is high, it is nephrogenic. If it is low, it is central or primary polydipsia. Then you look at your pituitary bright spot. Pituitary bright spot is lost. That means there is damage to the posterior pituitary. It is pituitary DI. If pituitary bright spot is still intact, then this is probably a primary polydipsia. Okay, fine. Now let us go on to the treatment. So how do you treat your diabetes insipidus? It is because of vasopressin deficiency. So you give your DDAVP, which is nothing but your vasopressin. You give it IV, SC, nasal or oral. It's available in multiple formations. Okay. And what usually we give is your nasal preparations. Onset is within 15 minutes. Okay. Onset is within 15 minutes. The only side effect which you have to worry about is probably your hypernatremia, but it is a rare side effect. Alright. For nephrogenic DI, it is not responsive to vasopressin. So what are all used? Usually it is your thiazide diuretics. Which have been tried for the management of nephrogenic DI. But in any form of DI, always try to find the underlying cause and treat the same. So this is about your diabetes insipidus and disorders of your posterior pituitary. Thank you.